Hi, I'm Dr. Tom Kravis, Physician Executive for 3M Consulting Services. Thank you for joining me. Today we're going to talk about ICD-10 documentation for infectious diseases. There are some changes you'll need to make in your documentation to support ICD-10, but there are other instances of documentation that can remain the same. Information about ICD-10 has gone viral, but by the time we're finished today, you'll see that ICD-10 is manageable. So let's get started.
I know you are busy in your clinical practice, so I will briefly summarize the key takeaways. In your documentation of patient care, consider the use of adjectives, link the cause and effect of each condition, be specific about aspects of a disease and each anatomical site, and document the organism when known or suspected. Remember that the coding professional is not permitted to glean this information from laboratory results. Rather, the information must be recorded in your notes in order for it to be captured and reported. A little more on each of these. Differentiate in your notes whether a condition is acute, subacute, or chronic whenever appropriate. For example, document hepatitis B as acute or chronic hepatitis B rather than simply hepatitis B. Use due to or secondary to indicate cause and effect and to record all conditions the patient may have, such as urethritis due to chlamydia or meningococcal meningitis. Consider in your documentation the most current terminology to describe the condition or different aspects of the disease. For example, foodborne staphylococcal intoxication or enterotoxigenic or enterohemorrhagic E. coli infection. Specify the anatomical site, such as TB of the meninges or an infection of the cornea due to or secondary to herpes virus. Document the organism you are treating when known or suspected, such as atypical pneumonia, probable mycoplasma. Ask yourself, what else could I add in my notes about this patient's condition that would better communicate how sick the patient is, which in turn better communicates the resources needed for patient care? Incorporating these aspects into your documentation will result in an accurate picture of your patient's severity of illness and risk of mortality. This in turn will result in accurate public reporting on quality and outcomes. And it will help reduce the number of queries you receive to clarify your documentation. In the upcoming slides, we'll take a look at some diseases and procedures that have new documentation requirements under ICD-10. What's new in ICD-10 with the Sepsis Continuum? Sepsis is classified to one of two categories in ICD-10, either streptococcal sepsis or other sepsis. Streptococcal sepsis is further specified as being due to Group A or Group B streptococcus, Streptococcus pneumonia, or other streptococcal infection. As mentioned earlier, the coding professional cannot use laboratory results such as a blood culture to code an organism, making it necessary for you to indicate a cause and effect relationship between the organism and the sepsis if known or suspected in your notes. There are now combination codes for severe sepsis or SIRS due to an infectious process with acute multi-organ dysfunction with or without septic shock. It is important to document shock as well as any associated organ dysfunction, such as acute respiratory failure, acute renal failure, acute hepatic failure, disseminated intravascular coagulopathy, and so forth, as they are important indicators of severity of illness and risk of mortality in the critically ill patient. Sometimes we use the term sepsis, bacteremia, septicemia, and severe sepsis interchangeably or indiscriminately in medical records. Make certain to clearly document the term that accurately describes your patient's condition and update it should the patient progress along the sepsis continuum as the condition is treated or resolved. On another note, should you have a patient with SIRS due to a non-infectious process such as trauma, ICD-10 requires you to document if there is associated acute organ dysfunction.
What is new with urinary tract infections is that the diagnosis of urosepsis can no longer be coded in ICD-10. In ICD-9, a diagnosis of urosepsis defaulted to the code for an unspecified urinary tract infection. If you record a diagnosis of urosepsis in the ICD-10 environment, it will generate a query asking you for clarification. If by using the term urosepsis, you mean the patient has a UTI, then document UTI.
However, if you mean the patient is septic from a urinary source, make sure to document this. For example, E. coli sepsis due to UTI. What stays the same with urinary tract infections in ICD-10 is that
if you know the site of the infection, it's important to note it, such as cystitis, urethritis, or pyelonephritis, and if the condition is acute or chronic. If the infection is related to a device, you must document this relationship, such as UTI due to indwelling Foley catheter. Lastly, if you know the organism causing the infection, make sure to document the cause and effect relationship in your note, such as E. coli UTI.
The only thing that has changed with regard to HIV disease in ICD-10 is the actual code number. It changed from 042 to B20. However, there is currently an opportunity for improvement in documenting this diagnosis. Sometimes we use the term HIV positive for patients who have AIDS. There is a different code for HIV positive status, which indicates that the patient's condition has not progressed to AIDS. Therefore, it is important to accurately state your patient's condition as either HIV positive or AIDS, or other similar diagnoses such as symptomatic HIV infection or ARC. There are not a great deal of new requirements here. As in ICD-9, ICD-10 can classify intestinal infectious diseases due to a variety of causes or organisms when documented by you. Specify the etiology and/or organism when known or suspected. Diagnoses such as gastroenteritis due to norovirus or suspect viral gastroenteritis convey more meaningful information than a diagnosis of gastroenteritis or a list of symptoms such as nausea, vomiting, and diarrhea. Document as much as you know or suspect about the gastroenteritis at the time of your evaluation and treatment. One change to take note of is that the term food poisoning has been eliminated from the ICD-10 code for the same. If you document food poisoning, the coding professional will be able to crosswalk this to the category for foodborne intoxication, but you must specify that the illness is foodborne in nature. What's new with viral hepatitis in ICD-10 is that there are now codes to distinguish between acute and chronic hepatitis B and C. If you don't specify the chronicity of hepatitis B and C, a code for unspecified viral hepatitis must be assigned. Hepatitis A and E are only classified as acute in ICD-10. What remains the same in ICD-10 is that the type of hepatitis needs to be documented as well as hepatic coma if present. In addition, the findings of a delta agent in the hepatitis B patient should be documented, as there are codes that indicate its presence with hepatitis B. This helps to better portray how sick your patient is. Another intestinal infectious disease is typhoid fever. There are approximately 400 typhoid fever cases occur each year in the United States, with 75% of these cases acquired during international travel. What's different about typhoid fever in ICD-10 is that there are new combination codes with the specificity to capture the complications of typhoid fever, such as meningitis or pneumonia. Therefore, if you happen to diagnose a case of typhoid, it would be important to document any complications that may occur as a result of the infection. If the patient is diagnosed with paratyphoid fever, it is important to specify the type of paratyphoid fever, for example, type A, B, or C. There are no new documentation requirements for tuberculosis in ICD-10. The one major change in the coding of TB in ICD-10 is that the method of determining the diagnosis of TB is no longer a factor in code assignment. In ICD-9, the information was captured in the last digit of the code, as seen on the right side of the screen. You will need to continue documenting the site or sites of the tuberculosis, such as lungs, meninges, or spine, to name a few. There is also a category for miliary or disseminated TB that can be assigned based on your documentation. As physicians are increasingly held accountable for patient outcomes, a major concern is how to classify the patient who fails to follow a recommended regimen of care and gets sicker as a result. Under ICD-9, there is only one generic code for such a patient that says non-compliance, with no additional detail as to why the patient didn't follow your instructions. But in ICD-10, there are several codes to describe why a patient is non-compliant in taking drugs prescribed by you. This new clinical terminology is drug underdosing. Underdosing identifies situations in which your patient has taken less of a medication than prescribed by you, either unintentionally or intentionally. Document in your notes why the patient isn't taking the correct amount of their medication and the associated condition. For example, patient under outpatient treatment for a urinary tract infection is admitted with acute pyelonephritis. After investigation, it was found the patient did not take the antibiotic prescribed for the UTI because antibiotics upset her stomach. Patient has age-related dementia and forgot to take her Cipro as prescribed. Or patient could not afford to pay for the antibiotic prescription. Even though few procedures are performed by infectious disease physicians, we'll still take a look at one, insertion of a PICC line, in order to give you some exposure to ICD-10 PCS codes and associated documentation requirements. In this example, you see the table used to code the insertion of a PICC line. The root operation definition for this procedure in ICD-10 PCS is insertion, which is defined as putting in a non-biologic appliance that monitors, assists, performs, or prevents a physiologic function but does not physically take the place of a body part. Pay particular attention to the column labeled approach. The coding professional should be able to determine from your notes if the PICC line insertion was done via a cut-down or open approach or a percutaneous approach in order to construct an accurate code. Even though it is more likely that most PICC lines are inserted via a percutaneous approach, the coder cannot make this assumption and must rely on documentation of the approach in your procedure note. The code for this procedure is 02HV33Z.
ICD-10 requires more detailed descriptions in your documentation of anatomical site and aspects of a disease, condition, procedure, and circumstances of patient encounters. The information generated from ICD-10 codes will result in a more accurate picture of your patients, their severity of illness, risk of mortality, and the services rendered. This in turn will result in accurate public reporting on quality and outcomes. Should you have questions about documentation for a particular diagnosis or procedure, your hospital's clinical documentation improvement specialist should be your first stop. The coding staff in your Health Information Management Department is a valuable resource as well. Thanks for joining me, and have a great day.